You know, usually when we talk about a medical diagnosis, there is this very comforting expectation of precision.
Oh, absolutely.
Like it feels almost like engineering, you know? If you fall and break your arm, you go to a clinic, the x-ray shows that jagged white line on the screen, and the doctor just points at it and says, there it is.
Hmm.
That is the problem.
Right. It is incredibly binary. And, you know, human beings naturally gravitate toward that.
Yeah.
We like our problems to be highly visible, and we like the solutions to be neatly categorized.
Broken or not broken, it's clean.
Exactly.
But then you step into the world of a massive humanitarian crisis.
Which is a whole different reality.
Completely. We are talking about a devastating natural disaster or a sudden explosive conflict zone, and suddenly that metaphorical X-ray machine is just completely shattered.
Yep, you're flying blind.
Right. We were looking at a diagnostic landscape that is entirely murky. I mean, when a massive crisis hits, we immediately see the incredible images on the news. You know the ones.
The cargo planes.
Yes. You see these massive C-130 cargo planes landing on dirt runways. You see enormous white medical tents going up overnight.
It's very cinematic.
It is. You see pallets of life-saving supplies being unloaded by these exhausted, heroic volunteers. It looks like an absolute miracle of modern logistics.
Because it is a logistical miracle, honestly.
It is. But for you listening, have you ever stopped and wondered, well, how do they know exactly what to pack in those boxes before they even know who is hurt?
That is the million-dollar question.
Right. And perhaps far more importantly, who is actually checking to make sure those doctors and logistical planners do a good job once they get there?
Which is something almost nobody thinks about.
No one. Because right now, as we are going to discover in this deep dive, the architecture of international aid is operating in a massive, almost invisible accountability void.
It is the absolute definition of diagnostic muddy waters.
Yeah.
And that is exactly what we are wading into today. We are looking deeply at the architecture of international aid. We aren't just looking at the inspiring logistics of it, though we will touch on that.
Right.
We are scrutinizing the governance of it. Who holds the power and who holds the responsibility?
So our mission today is to explore this fascinating, highly complex, and honestly, shockingly unmonitored world.
Shocking is the right word.
We are talking about the literal life and death mechanics of saving millions of vulnerable people and the incredibly messy reality of trying to be a quote-unquote good actor in a fundamentally broken system.
And we have some incredible sources to unpack this.
We really do. To do this, we are synthesizing three incredibly revealing sources that span several decades of humanitarian history.
Three very different perspectives.
Yeah, first we have a foundational 2003 diplomatic agreement. It's known as the 24 Principles and Good Practice of Humanitarian Donorship.
Which is kind of the diplomatic rule book.
Exactly. Then we are going to look at a truly historic, paradigm-shifting 1982 medical paper published in The Lancet.
I love this paper.
It's amazing. It essentially created the underlying mathematical formulas for all modern crisis response.
The map of saving lives.
Right. And finally, we will unpack a hard-hitting 2021 academic survey published in the journal Conflict and Health.
Which brings us right into the modern day.
It does, and it exposes some deeply alarming gaps in how modern international non-governmental organizations,
What we generally call NGOs.
right, NGOs, how they are actually governed when no one is watching.
So we are taking you on a chronological and structural journey today.
Yeah, buckle up.
We will start with the high-minded ideals constructed by diplomats, then we'll descend into the gritty, brilliant mathematics of packing an emergency medical kit.
Which is wilder than it sounds.
Oh, it really is.
Yeah.
And finally, we will confront the modern boardroom reality of global charities.
Let's unpack this by starting with those ideals, the blueprint of humanitarianism. Take us back to 2003. What was happening in the world that forced this massive conversation?
Okay, let's set the historical scene. It is 2003, and the government of Sweden convenes a major, unprecedented meeting.
In Sweden. Okay.
Yeah. You have representatives from 16 different major donor governments. You have the European Commission.
Wow.
You have the OECD, which is the Organization for Economic Cooperation and Development. Essentially a club of the world's wealthiest donor nations.
The people with the money.
Exactly, the check writers.
Mm-hmm.
You also have the International Red Cross and Red Crescent movement, numerous massive NGOs, and top-tier academics.
Okay, so that is a lot of very powerful people in one room. Why then? Why specifically 2003?
Because the late 1990s and early 2000s had exposed a massive, undeniable problem.
A problem with how we gave aid.
Yes. Following the complex emergencies in places like Rwanda, the Balkans, and the early days of the conflict in Afghanistan,
Yeah.
there was a growing realization that the world of humanitarian aid was becoming incredibly fragmented,
Fragmented how? Like uncoordinated.
highly uncoordinated. Before this meeting, you could have a situation where one country gives $50 million in aid, but they attach a completely different set of expectations to it.
Ah.
Or worse, political strings, compared to another country funding the exact same crisis.
So country A might say, here is food, but you can only give it to the refugees who support our geopolitical allies.
Yeah.
While country B says, well, here is medicine, but you have to put our giant flag on the tent.
Exactly. It was a total free-for-all.
That sounds like a nightmare for the people actually trying to run the camps.
It was. The entire system was lacking coherence. So the goal of this 2003 meeting in Sweden was to enhance the effectiveness of donor action, to establish a universal baseline.
To get everyone on the same page.
Right. And crucially, to define what good donorship actually looks like on a global scale.
Okay.
So they drafted these 24 principles. And at the very heart of this document, right up front in Principle 2, they enshrined 4 core principles.
The 4 pillars.
The 4 pillars. And these are supposed to be the absolute non-negotiable North Star for all humanitarian action globally.
Let's walk through them because they sound simple on the surface, but the implications of actually executing them in a war zone are massive.
Totally. So the first pillar is humanity.
Humanity?
The document explicitly defines this as the centrality of saving human lives and alleviating suffering wherever it is found.
Okay.
It is the absolute baseline moral imperative. If a human life is at risk, you act to save it. Full stop.
It sounds like the global Hippocratic Oath. First, save the life.
Yes, very much so.
But wait, saving lives indiscriminately sounds great in a boardroom in Sweden, but what if saving a life actually jeopardizes your mission?
What do you mean?
Well, what if treating a wounded rebel fighter means the local government gets furious and kicks your entire NGO out of the country? How do they balance that?
And that tension is exactly why the second pillar exists, which is impartiality.
Impartiality. Okay.
Impartiality dictates that humanitarian action must be implemented solely on the basis of need, without any discrimination between or within affected populations.
So the severity of the wound dictates who gets the hospital bed,
Exactly.
not the uniform the person is wearing.
Correct. You do not prioritize one ethnic group over another. You don't prioritize one religious group over another. And you certainly don't prioritize one political faction over another.
So you are completely blind to everything except the medical chart.
The only metric that matters is who needs the medical help the most in that exact moment.
Which is incredibly difficult to execute perfectly in a chaotic environment where, locals are armed and demanding you pick a side.
Oh, it's terrifying in practice.
But as a guiding ideal, it's undeniable. Okay, then we get to the third and fourth pillars, which are neutrality and independence.
Yes.
And here is where I really had to pause and reread the source text because they sound incredibly similar, almost redundant.
You're not alone in that. They frequently get conflated, even by people working tangentially in the sector.
Yeah.
But the distinction between the two is absolutely critical to how aid functions.
Okay, because the text specifically says neutrality means humanitarian action must not favor any side in an armed conflict or other dispute.
Right.
And then it defines independence as the autonomy of humanitarian objectives from the political, economic, military, or other objectives that any actor may hold.
Right.
So honestly, is independence basically just neutrality with a budget attached?
That is a remarkably accurate way to frame it. I really like that. To break it down functionally, neutrality is about your physical behavior and your posture on the ground regarding the conflict itself.
Like your physical actions in the camp.
Exactly. It is the strict refusal to pick a side in the fight. If you treat a wounded rebel soldier in the morning, you must be equally willing to treat a wounded government soldier in the afternoon.
Right.
You do not engage in the hostilities, and you do not make public statements denouncing one side's military tactics.
Yeah.
You are basically a ghost to the politics of the war.
Okay, so neutrality is about who you treat and how you act inside the actual war zone. It's operational.
Yes. Independence, however, is about your relationship with the people funding you back home.
Back in London or Washington?
Right. It is the absolute refusal to let the person writing the multi-million-dollar check dictate the terms of the fight or the aid.
Give me an example of how that tension actually plays out in the real world.
Okay, imagine a wealthy donor government gives a major medical NGO $50 million.
Huge grant.
Huge. But in the fine print, the government says, we only want you to use this money to build clinics in this specific southern region.
Okay.
Because the people in the southern region are our political allies, and we want to stabilize that area.
Right. It's foreign policy disguised as aid.
Exactly. Now, an independent humanitarian organization has to look at that $50 million and say no.
Wow.
They have to say, we have assessed the country, and the greatest medical need is actually in the northern region.
Where the political enemies are.
Right. So they say, we will go where the need is greatest, regardless of your foreign policy objectives. If you don't like it, keep your money.
Wow. That takes an unbelievable amount of spine. I mean, think about the pressure on the CEO of that NGO.
It's immense.
They are desperate for funding to fulfill the first principle, humanity. They want to save lives.
But they have to reject massive amounts of money if it violates the principle of independence.
It's a constant, agonizing tightrope.
It is the central defining friction of the entire humanitarian sector. And the 24 principles try to build guardrails to reinforce this independence across the board.
What kind of guardrails?
For instance, Principle 19 explicitly affirms the primary position of civilian organizations in implementing humanitarian action.
Civilian, not military.
Right. It bluntly states that military assets should only be used as a last resort.
Okay.
And even then, only in strict conformity with international law, while always recognizing the leading role of the civilian organizations.
So the rule is essentially keep the military out of the medical tent unless it is absolutely unavoidably necessary for survival.
Basically, yes.
But why are they so strict about that? I mean, a military cargo plane can drop off a lot of supplies very quickly. The military is great at logistics.
They are, but it's because of the optics and the devastating consequences of blurring the lines.
The optics.
Yes. Once military forces, who are active combatants with weapons, start handing out food or administering vaccines, the local population can no longer tell the difference between a soldier and an aid worker.
Oh, I see.
Yeah.
If a rebel faction sees a military truck delivering bandages, they might assume the medical tent is a military outpost.
Precisely. It puts the principle of neutrality at immense risk. And more tragically, it puts the unarmed civilian aid workers at extreme risk of being targeted and killed.
Because they are perceived as part of the military apparatus.
Exactly. They lose their shield of neutrality.
That makes complete sense. Now, looking beyond the 4 pillars, there was another principle here that really caught my eye. Principle 6.
Yes. The needs assessment principle.
Right. It states that donors should allocate humanitarian funding in proportion to needs and strictly on the basis of needs assessments.
Which is a very logical requirement. You put the financial resources and the medical supplies exactly where the fire is hottest.
Right. It's a beautiful concept on paper. But as I was reading it, it raised a massive, practical, almost terrifying logistical question for me.
Okay, let's hear it.
Let's play this out. You have a population of, say, 10,000 people who have just been displaced overnight.
Okay.
Let's say a catastrophic earthquake levels their city, or a sudden violent conflict forces them to flee across a border.
Very common scenario.
They're currently sitting in a muddy field with nothing but the clothes on their backs.
Right.
Principle 6 says you must allocate funding based on a quote-unquote needs assessment.
Right.
How on earth do you assess the specific medical needs of 10,000 panicking, traumatized people overnight?
You really can't.
I mean, you cannot walk through that field with a clipboard and interview 10,000 people in 24 hours to find out who has asthma, who has a heart condition, who is pregnant, or who urgently needs broad-spectrum antibiotics.
You absolutely can't. The logistics of individualized assessment in the acute phase of a crisis are impossible.
Right.
And for a long time in humanitarian history, the response was largely driven by well-intentioned guesswork.
Just guessing what people might need.
Yes. And that guesswork led to incredible, sometimes fatal inefficiencies.
What kind of inefficiencies? Give me an example.
You would have cargo planes arriving in tropical equatorial crisis zones packed full of frostbite medication.
You're kidding.
No, I'm serious. Or you'd have a massive shipment of highly specialized surgical tools arriving at a refugee camp where the actual urgent problem was an outbreak of waterborne cholera.
And cholera just requires basic rehydration salts, right?
Exactly. People were sending what they had in their warehouses, not what was actually needed, because calculating the needs seemed impossible.
So we know the diplomats in Sweden in 2003 demanded that aid allocated based on need.
Yes.
But practically speaking, if that earthquake hits a remote village tonight, how do you mathematically calculate that need by tomorrow morning so the cargo planes are packed correctly?
And that logistical nightmare is exactly what brings us to our second source.
Yes. Let's get into the math.
To understand how we conquer that impossible math, we have to travel back a few decades prior to the Sweden meeting.
Back to the 80s.
We are looking at a truly groundbreaking, paradigm-shifting paper published in 1982 in the prestigious medical journal, The Lancet.
Okay.
It was authored by Stephanie Simmons and Godfrey Walker, who were working out of the London School of Hygiene and Tropical Medicine.
The title of the paper is admittedly a bit dry.
A bit, yes.
It's called Essential Drugs for Primary Healthcare Standard Packages. But when you actually read what they accomplished, it is thrilling.
Thrilling is right.
What this paper did was essentially invent the mathematics of predicting illness in a crisis.
It is arguably one of the most consequential logistical papers in modern medical history.
Really?
Oh, absolutely. Simmons had been deeply involved in the healthcare of refugees and managing emergency drug supplies in the field. She witnessed the chaos of the guesswork firsthand.
The frostbite medication in the jungle.
Exactly. She realized that you cannot wait for the disease to show up at the clinic door. You have to statistically predict the illness before it even happens, so the drugs are already waiting on the shelf.
This paper is basically the architectural blueprint for every emergency medical kit used by organizations around the world today.
It is.
But how did they actually do this in 1982? I mean, this is long before big data algorithms or advanced computer modeling.
That is where their brilliance shines through. They couldn't know the exact demographic makeup of every single future refugee camp or disaster zone.
Because every disaster is different.
Right. So they created a mathematical abstraction. They defined a theoretical standard population of exactly 10,000 people.
10,000 is a nice, clean, scalable number to work with.
It is.
If a camp has 50,000 people, you just multiply everything by 5.
Exactly. But to make this standard population realistic, they based it on demographic data heavily drawn from developing countries at the time.
Okay.
They assumed a specific, highly vulnerable age structure. They calculated that exactly half of this displaced population,
5,000 people.
right, 5,000 people would be children under 15 years old. The other 5,000 would be adults.
Okay, so you have your imaginary, terrified town of 10,000 people sitting in a field.
Yep.
Half kids, half adults. Even if you know their ages, how do you mathematically know how often they're going to get sick over the next few months?
Well, they didn't just guess. They went analog.
Okay.
They painstakingly looked at physical outpatient clinic reports from developing countries across different continents.
Actual paper records.
Yes.
Okay.
They compiled this raw data and estimated that the likely average number of what they called curative contact,
Or curative contact.
essentially a single interaction between a sick individual
Yeah.
and a primary healthcare worker.
A doctor visit.
A doctor visit. They estimated the average would be roughly 4 per year.
4 doctor visits a year per person on average.
Right. So if you take a population of 10,000 people and you are planning for a 3-month period,
Why 3 months?
that is the standard emergency planning window before more permanent infrastructure can be built.
Got it. Okay, so 10,000 people for 3 months.
You are looking at exactly 10,000 patient contacts.
10,000 people, 10,000 medical visits in a 90-day window. The math is incredibly elegant.
It's very clean.
But here's where it gets genuinely mind-blowing. They didn't just estimate the total volume of visits. They predicted the exact symptom breakdowns.
Yes, down to the percentage.
They essentially looked at the global historical data and said, if 5,000 children walk into a clinic over the next 3 months, here is exactly what they will be suffering from.
And we have the data right here in Table I of their paper. The specificity is remarkable.
Let's hear it.
For the children aged 0 to 14, they predicted that 30% of the symptoms presented would be respiratory issues.
30%, okay.
20% would be severe diarrhea. 13% would be malaria. 10% would be helminths.
Which are parasitic worms, right?
Yes, worms. And another 10% would be skin conditions or physical trauma.
Let's pause on that, because this isn't just dry data. This is a terrifying story of what happens to the human body when infrastructure vanishes.
A very grim picture.
Think about it. Why are 30% of the kids suffering from respiratory issues? Because they are sleeping in crowded, poorly ventilated tents with indoor cooking fires, breathing in smoke and dust.
Exactly.
Why are 10% suffering from parasitic worms? because in a crisis, the very first thing to break is sanitation.
Clean water mixes with raw sewage.
Right. The data perfectly reflects a horrific reality of the environment.
And the breakdown shifts significantly when they modeled the adults.
What did the adult data look like?
For the 5,000 people aged 15 and above, they predicted 20% respiratory issues, 15% digestive issues, 15% diarrhea, 12% genitourinary problems, 10% malaria, and notably 15% musculoskeletal problems.
Musculoskeletal, like aches, pains, strains, injuries.
Yes.
Which makes total sense because who is doing the heavy labor in a refugee camp?
The adults.
The adults are the ones carrying the 40-pound jerrycans of water for miles, chopping wood and trying to physically rebuild shelters.
Exactly. And because they had these highly specific, mathematically rigorous predicted incidences, they could then map out the exact standardized treatment schedules.
Oh, because they know what cures what.
Right. They knew the exact pharmaceutical protocols for
Okay.
each symptom. So if your model expects 1,000 cases of childhood diarrhea based on the percentages, you know that the standard treatment is exactly 3 sachets of oral rehydration salts per child.
Wow.
Therefore, your cargo plane must pack exactly 3,000 sachets. Not 2,000, not 10,000, exactly 3,000.
It's incredible. I was trying to wrap my head around the scale of this, and I realized it's a lot like running a massive, high-stakes pop-up restaurant.
Okay, I like this.
Imagine a head chef trying to predict exactly how many people out of a crowd of 10,000 will order the chicken versus the fish.
Right, so they don't buy too much of one.
Exactly. So they know exactly how many lemons and sprigs of thyme to buy so nothing goes to waste and nobody goes hungry.
Yeah.
But instead of predicting a preference for chicken or fish, Simmons and Walker were predicting exactly how many human beings will need piperazine syrup to clear parasitic worms versus how many will need phenoxymethylpenicillin to survive a lower respiratory tract infection.
And they did it down to the exact milligram and the exact tablet count.
It's wild. The pop-up restaurant is a brilliant analogy, but with the stakes raised to life or death.
And it wasn't just an intellectual exercise published in a journal.
No.
This specific mathematical modeling formed the absolute bedrock for the World Health Organization and the UNHCR.
The UN Refugee Agency.
Yes. It led to the creation of the standardized emergency health kits that are still the gold standard used across the globe today.
So they still use this math.
Absolutely. If an earthquake hits Nepal tomorrow, a prepackaged, standardized kit based on these very mathematical principles, scaled to the estimated population size, is instantly put on a cargo plane.
Wow. But what I found so compelling about the 1982 paper is that Simmons and Walker actually took the time to explain why getting this math right matters so much.
It's not just about efficiency.
No, it's not just about logistics or saving money on shipping weight or pleasing accountants. It is fundamentally about psychology, and it's about trust.
The psychological component is arguably the most vital takeaway of their whole paper.
Break that down.
In their discussion section, they explicitly state that the success of primary healthcare workers depends substantially on the support they receive from this supply chain
Okay.
to be successful in their broader preventative roles, like convincing a skeptical, traumatized population to boil their drinking water or to trust a brand new vaccination campaign.
Right.
To do that, the health workers must first be seen providing what the authors call credible first-line curative services.
Credibility. That is the magic word here.
Yes.
Put yourself in the shoes of a refugee for a second. Imagine you have walked for a week to escape a war zone. You have lost your home, you have lost everything you own, and you are terrified.
It's unimaginable.
And your child has a severe hacking respiratory infection and is running a high fever. You stand in line outside a white medical tent in the blistering heat for 5 hours.
Right.
If you finally get to the front of that line and the exhausted health worker looks at you and says, "I'm so sorry, our logistical planners back in London miscalculated the math. We are completely out of penicillin," what happens?
The trust evaporates instantly. It shatters.
Exactly. The aid worker loses all credibility in the eyes of that mother. If you cannot cure the immediate, visible, agonizing pain right in front of you because your supply chain failed, why on earth would that mother listen to you tomorrow when you try to lecture her about the invisible dangers of unwashed hands or microscopic bacteria?
She wouldn't.
The entire public health system collapses without that initial transactional trust.
The broader implication here is that what Simmons and Walker proved in 1982 is that the physical availability of the right pill in the right quantity at the exact right time is the psychological anchor for all subsequent public health interventions in a crisis.
That's beautifully put.
If you get the math wrong, you don't just run out of drugs, you run out of authority.
Okay, so let's summarize where we are in this journey.
Good idea.
By 2003, we established the noble ideals, the diplomatic principles of how we should act. Neutral, impartial, independent. And all the way back in 1982, we figured out the heavy logistics. We built the mathematical models. We know exactly how to pack the boxes. We know exactly what drugs to buy. And we know how to put them on the cargo planes.
We solve the math.
We solved the math. But as we move into our third source, we hit a massive institutional wall.
A very modern wall.
Because as we are about to see, standardizing the stuff inside the boxes is very, very different from standardizing the system of the human beings handing them out.
Humans are much harder to standardize than pills.
Much harder. We know how to monitor the medicine, but who is watching the watchman?
And this is where we transition from the inspiring theory of aid into the rather sobering modern reality.
Yes, the 2021 survey.
We are looking at a comprehensive 2021 study published in the journal Conflict in Health. It was authored by Prudence Jarrett and a team of colleagues.
And the title?
The paper is titled Healthcare Governance During Humanitarian Responses, a survey of current practice among international humanitarian actors.
And just to set the immense scale of why this matters right now, today, the paper notes that in 2019, 168 million people worldwide required humanitarian assistance.
168 million.
Just visualize that. That is more than the entire population of Russia, entirely displaced or in crisis.
It is a staggering, almost incomprehensible number of human beings who are entirely dependent on external foreign actors for their basic daily survival, including their most critical health care.
Yeah.
And what this paper investigates is a massive, almost completely invisible structural flaw in the global aid system that serves them.
The accountability void.
Exactly. The researchers define the modern humanitarian system as a loose network of mostly autonomous actors.
Autonomous meaning no one is in charge.
Right. You have massive multilateral UN agencies, you have the Red Cross, and you have dozens of massive multi-million-dollar international NGOs. But here is the critical defining issue. This entire global network is not governed in the conventional sense. There is no overarching global body, no international medical commission that they all legally answer to.
Wait, hold on. Let's really pause and dissect this. Because when I read this part, I don't think people realize how wild this is.
It's very counterintuitive.
If I go to a local clinic here in my hometown, or if I check into a local hospital, there is a dense web of oversight.
Oh, absolutely. Red tape everywhere.
There are state medical boards. There are licensing authorities that can revoke a doctor's right to practice. There are malpractice lawsuits.
Yep.
There are endless layers of local, state, and federal regulations, ensuring that the doctor treating me isn't doing something incredibly dangerous or experimental.
Right.
Are you telling me that a $50 million NGO operating a massive field hospital in a disaster zone is basically running on the honor system?
In many fundamental structural ways, yes. The paper outlines this accountability void very clearly. Let's look at it from the perspective of the beneficiaries, the patients in the camp.
Okay.
If a multilateral organization, like a United Nations agency or the World Health Organization, makes a catastrophic error, they are generally exempt from any legal accountability in the countries where they operate.
Why?
Because their staff usually possess diplomatic immunity.
Okay. I mean, I somewhat understand diplomatic immunity for UN officials to prevent local corrupt governments from arresting aid workers on bogus political charges.
That is the intended purpose, yes.
But what about the NGOs? They aren't the UN. A private British or American charity operating in South Sudan doesn't have diplomatic immunity.
True, they do not. But look at where the regulatory scrutiny would theoretically come from.
Okay.
First, you have the country where the NGO is headquartered, the home country, say the UK or the US.
Right.
The charity commissions in those home countries, like the UK Charity Commission, are incredibly strict about monitoring financial fraud.
They want to make sure the money isn't stolen.
They will audit every penny to ensure money isn't being embezzled. But they do not proactively monitor the clinical quality of the medical services those NGOs provide overseas.
Oh.
The UK government isn't sending health inspectors to a refugee camp in the Democratic Republic of Congo to check if a British NGO is following proper surgical hygiene protocols.
Right, because it's completely outside their jurisdiction.
Exactly.
Okay, so what about the host country? the actual country where the disaster is happening and where the NGO is operating.
In theory, on paper, the NGO is strictly subject to the laws and the Ministry of Health regulations of the host government. But in practice, international humanitarian actors are usually deployed precisely because the host country is in a state of catastrophic collapse.
Right.
There is often a total breakdown of law and order.
Yeah.
The local Ministry of Health might have been physically destroyed in an earthquake, or their staff might have fled a war zone.
So there is no one left to enforce the rules.
The host government simply does not have the administrative capacity or the personnel to regulate, audit, or penalize an influx of dozens of foreign, highly funded medical organizations.
So you have these massive organizations wielding immense life-altering power. They are deciding who gets surgery, who gets vaccines, how a cholera epidemic is managed.
Yep.
And they are doing all of this while operating in a complete vacuum of formal legal accountability.
And the researchers point out that this lack of oversight leads to a very specific, vastly under-discussed danger.
What is that?
We all intuitively understand clinical malpractice.
Like a botched surgery.
Right. That's when a specific surgeon botches an operation or a tired nurse administers the wrong dose of a drug to a single patient. That happens everywhere, and it's a tragedy.
Yeah.
But the study introduces a broader, potentially far more devastating concept: public health malpractice.
Public health malpractice. Explain the mechanism of that. What does that actually look like on the ground?
It is about systemic, managerial decision-making that harms entire populations.
Okay, give me an analogy.
Let me use an analogy. Clinical malpractice is like a chef in a restaurant accidentally burning your steak, ruining your dinner.
Right.
Public health malpractice is the restaurant management deciding to stop serving food entirely and only sell expensive cocktails, even though everyone in the town is starving.
Just because it's more profitable?
Simply because the management realized cocktails are more profitable for the investors.
That is a chilling analogy. So in the aid world, public health malpractice is what? Shutting down a clinic?
It could be an NGO abruptly shutting down a highly effective, crucial vaccination program in a camp, simply because a donor back in Geneva suddenly shifted their funding priorities to a different country.
Wow.
It could be an NGO deciding to focus all their medical staff and resources on a high-profile, rare disease that is getting a lot of attention on CNN.
While ignoring something else.
While completely ignoring a localized, rampant outbreak of measles that is actually killing 10 times more children.
Because measles isn't making the news.
Exactly. It is fundamentally inappropriate, systemic decisions on which health services to provide, driven by institutional priorities rather than patient needs.
And because these are systemic administrative decisions made in boardrooms, the body count can be absolutely enormous, but there is no single botched surgery or smoking gun to point a finger at.
No.
It just looks like a tragedy.
Precisely. And to give some context to the global scale of healthcare quality issues, the paper cites a staggering statistic. Globally, harmful healthcare practice affects 1 in 4 outpatients, leading to an estimated 2.6 million preventable deaths annually.
2.6 million preventable deaths.
Now, that is a general global statistic across all health systems, but it serves to highlight that when healthcare governance is weak, millions of people die unnecessarily.
And these refugee camps are the weakest systems on Earth.
Humanitarian responses are highlighted as an area of extreme concern because the displaced populations are the most vulnerable people on Earth.
So, because there is no global medical board to audit these NGOs, the researchers of this 2021 study decided they needed to figure out exactly how these organizations are operating in this wild west of accountability.
Yes, they surveyed them?
They surveyed senior health professionals, medical directors, and advisors at 13 of the leading international humanitarian actors. We are talking about the big players.
Organizations operating across multiple continents, receiving hundreds of millions in funding.
Right. What did they ask them?
The researchers wanted to understand what internal rules, structures, and mechanisms these organizations voluntarily put in place to ensure they are providing safe care.
Okay.
They graded them across 7 specific domains of healthcare governance.
Okay, let's open up this governance report card. Let's start with the good news, because I don't want people thinking the whole system is entirely broken.
It's not.
There are areas where they excel.
Absolutely. The domain that scored the absolute highest for effectiveness across all the surveyed organizations was pharmaceutical supply.
Which is such a deeply satisfying link back to our 1982 paper.
It really is.
It essentially proves that Stephanie Simmons and Godfrey Walker's work from 40 years ago actually paid off. We mastered the physical drug supply chain.
Yes, the logistical frameworks they pioneered hold up beautifully. The survey found that 93.8% of the organizations have a designated, dedicated project leads specifically for pharmaceutical supply.
Wow, almost all of them.
They have incredibly strict guidelines and standard operating procedures for procurement, for safe disposal of expired drugs, and most impressively, for maintaining cold chains.
Let's actually talk about the cold chain, because I feel like the general public hears that term but doesn't realize what a monumental logistical achievement it is. A cold chain isn't just a cooler with some ice.
Far from it. A cold chain is the uninterrupted system of storing and transporting vaccines and medicines at a specific temperature range,
Usually what, like fridge temperature?
usually between 2 and 8 degrees Celsius. And this has to be maintained from the moment they leave the manufacturing plant to the moment they are injected into a patient's arm.
So imagine a measles vaccine manufactured in a pristine factory in Belgium.
Okay.
It gets loaded onto a refrigerated truck, then onto a cargo plane. It lands on a sweltering 110-degree tarmac in Nairobi.
Right.
It gets loaded into the back of a Land Cruiser that drives for 12 hours over jarring dirt roads in South Sudan, and finally arrives at a medical tent powered by a sputtering, unreliable diesel generator.
And through all of that,
If that vaccine hits 15 degrees for even a few hours during that entire journey, the proteins degrade, the vaccine is useless, and the child who receives it is completely unprotected.
exactly, and is a logistical tightrope. And the fact that the 2021 study showed nearly 94% of these massive organizations have mastered the procedures to prevent that degradation is a modern operational miracle.
But as we've learned in this deep dive, there is always a catch.
There is.
There is an expert caveat here regarding the pharmaceuticals, isn't there?
There is a significant one.
Hmm.
While the physical supply chain, getting the box to the tent, is highly monitored and governed, what happens after the drug changes hands and goes to the patient is much weaker.
Okay.
The paper notes that pharmacovigilance is severely lacking.
Break down pharmacovigilance for me. What does that mean?
Pharmacovigilance is the structured, scientific monitoring of a drug's side effects after it has been dispensed, and the active supervision of rational prescribing by doctors.
Okay, so tracking what happens after they take the pill.
Yes. The survey found that only 37.5% of the organizations reported conducting structured pharmacovigilance.
So let me make sure I'm understanding this. We can move a fragile blister pack of pills across an ocean, through a war zone, keep it perfectly chilled, and put it directly into a refugee's hand with 94% effectiveness. But once they actually swallow the pill, we essentially stop watching. We aren't tracking if it gave them a terrible allergic reaction, or if the exhausted doctor is just prescribing broad-spectrum antibiotics for a viral cold because they don't have time to properly diagnose the patient.
That is the blind spot.
Yeah.
The logistics are tightly governed. The clinical aftermath is not.
Wow.
And this theme of meticulously tracking the logistics while ignoring the outcomes brings us to a highly distorted domain in the report card,
Which is?
HMIS, or Health Management Information Systems, basically how they handle health data.
This part of the study was genuinely eye-opening and a little infuriating.
It's very revealing.
So these organizations are operating in the modern digital age. The study shows that 81.3% of the NGOs use digital data systems.
Yes.
Things like DHIS2, which is a massive open source database platform used by dozens of countries, or even just gigantic complex Excel spreadsheets. They're collecting mountains of data on the patients they treat.
But the critical, revealing question the researchers asked wasn't if they collect data, but why are they collecting this data?
Right, or what is the goal?
What is the actual mechanism and purpose behind the software?
And the answers they received are so telling. 87.5% of the organizations admitted they use their health data primarily to report back to their donors.
Let that sink in.
But only 31.3% use that exact same data to provide health feedback to the beneficiaries, the actual patients and local communities.
That's a huge gap.
And a dismal 18.8% use the data for cost-effectiveness analysis to see if they are wasting money.
When you zoom out and look at those numbers, what does that actually mean for how a clinic operates?
It means we are obsessively collecting data. We are counting every single pill dispensed, every bandage wrapped, every bed occupied, not to figure out if we actually cured the patient.
Exactly.
And not to figure out if we are running the clinic efficiently. We are collecting data solely to generate a receipt.
A receipt for the donors.
We are doing it to prove to the wealthy donor in London or Washington or Geneva that we did exactly what they paid us to do. It's auditing for accountants. It's not diagnostic data for doctors.
And we have to explain the mechanism of why this happens. It's not because the NGOs are inherently malicious.
Oh.
It's because of how donor grants are structured. If a donor government gives an NGO $10 million, that grant comes with strict legal compliance requirements.
Like quotas.
Yes, the donor requires proof that 50,000 malaria treatments were delivered. If the NGO cannot provide that specific data, they do not get their grant renewed next year.
Wow.
So the software, the DHIS2 system, is physically coded and configured to generate donor compliance reports.
Right, so the data entry clerk sitting in a sweltering tent in the camp is forced to spend 4 hours a day logging compliance metrics, just hash marks for pills given.
Exactly.
But there might not even be a field in the software for, did the patient actually recover from malaria? The software is rigged to satisfy the person with the checkbook, not the person with the illness.
The researchers included a specific anonymous quote from a participant in the study, identified as participant 15, that perfectly encapsulates this trap.
Read it.
They said, and I quote, "Each country program is collecting their data in different forms based more on donors and cluster requirements rather than for quality improvement purposes."
Rather than for quality improvement purposes, that is a devastating admission from someone high up in the system.
It really is.
The data is entirely backward-looking to secure the next round of funding. It is not forward-looking to improve the medicine.
And this donor-centric focus, this constant anxiety about pleasing the people with the money, doesn't just affect software and spreadsheets. It deeply infects the culture. It dictates how these organizations treat their own human resources, how they train their staff, and, most alarmingly, how they handle their own fatal mistakes.
Which brings us to the human element of this survey. Let's look at the domains of blame, nepotism, and mistakes. Let's start with professional development. You are deploying medical staff into the most complex, traumatic, high-stress environments on Earth.
Unbelievable stress.
You are asking them to do trauma surgery in a tent. You would assume their training is top tier, fiercely protected, and constantly updated.
Well, on paper, the survey suggests it is. 75% of the surveyed organizations say they offer structured training and development packages for their health sector staff.
But then the researchers dug into the actual budgets beneath the official corporate policies.
Yes. Less than half of the organizations actually have a protected, guaranteed budget for professional development.
Less than half.
And fewer than 20% have a formal pathway to officially accredit their staff for the new skills they learn.
This is where the anonymous quotes from the survey participants get shockingly candid. I could not believe some of these responses when I was reading the source material.
Participant 14.
Yes. Participant 14 noted that, yes, technically there is a budget proportion dedicated to training, but it is never fully utilized because, and I'm quoting here, staff do not know that it exists and HR is usually not very open on sharing information about it.
You have a multi-million-dollar organization actively hiding its own life-saving training budget from its frontline medical workers.
Oh, hi.
Presumably to save money or use it elsewhere.
And it gets worse. Participant 3 admitted the quiet part out loud. I quote, "It is through personal relationships and personal endeavor that higher-level staff get training opportunities."
Nepotism, pure and simple.
I just want the listener to really imagine the stakes of that.
Yeah.
Think about why nepotism happens. It happens because of scarcity. The NGO only has enough budget to send one doctor to Geneva for an advanced pediatric trauma life support course.
Right.
Instead of sending the most promising surgeon, the HR manager picks their friend.
Yeah.
The consequence of that office politics is that 3 months later, a less qualified surgeon is operating on a 10-year-old earthquake victim in an active disaster zone.
It's tragic.
Life-saving emergency medical training is being dictated by who you get lunch with at headquarters. That is terrifying.
It reveals a profound, deeply unsettling disconnect between the outward-facing heroism of humanitarian work, the images we see on TV, and the internal, sometimes petty, corporate reality of how these NGOs actually function behind closed doors.
Absolutely.
But as bad as the training issue is, the most concerning finding of the entire 2021 study, the domain that scored the absolute lowest on effectiveness.
Dismal 2 out of 5.
A 2 out of 5. It was incident management.
Incident management. This is the protocol for what happens when things go horribly wrong. When patient dies unnecessarily, when a sterile surgical protocol is breached, or when a dangerous drug is administered incorrectly.
The survey found that while 62.5% of organizations have a formal system for reporting incidents, meaning there is a form you can fill out, only 40% actually have an established functioning process for investigating those incidents once they're reported.
So, more than half the time, a nurse witnesses a catastrophic medical error. They fill out a form saying, hey, a terrible mistake happened here. They put it in a box, and nothing happens.
Nothing happens.
There is no structural mechanism to investigate why the wrong drug was given or how to change the pharmacy layout to stop it from happening to the next patient.
Furthermore, the researchers found that international NGOs often utilize jurisdictional loopholes to dodge responsibility entirely.
How so?
When a major clinical incident occurs, the NGO will often claim that clinical care technically falls under the local host country's Ministry of Health protocols.
Oh, wow.
They essentially pass the buck. They say, well, we are just a foreign guest supporting the local clinic, so if a patient dies from malpractice, it is the local government's responsibility to investigate.
Even though, as we already established, the local government's infrastructure has likely been decimated by the crisis, and they lack any capacity to do so. It's a bureaucratic shell game. It's a loophole that allows fatal medical errors to just vanish into the ether without anyone ever being held accountable.
And why is this happening? Why would organizations dedicated to saving lives bury their own mistakes?
Right, why?
The authors of the study point directly to the institutional culture. Participant 6 provided a very illuminating, tragic quote. We are trying to change the culture to be less of blame and more of learning, but this is an uphill battle.
Blame culture.
Exactly. Think about the accountability void we discussed earlier.
No.
When an organization lacks independent, objective, supportive regulatory oversight and instead relies entirely on maintaining a pristine public image to secure donor funding, admitting a mistake is no longer a medical learning opportunity.
Right.
Admitting a mistake is viewed as an existential threat to the organization's survival.
Right. If a doctor admits they made a massive error in a cholera camp, they fear they will be fired. The NGO managers fear that if the error is made public, USA or the European Commission will pull their $10 million grant. So, because everyone is terrified of the financial repercussions, errors get buried.
And if the error gets buried, the lesson is never learned. The system never improves.
Right.
The exact same public health malpractice, the exact same logistical failure will be repeated in the next earthquake, in the next refugee camp, 5 years down the line. It is a cycle of uncorrected failure, completely masked by good intentions.
Which leads us to the ultimate victim of this broken system. Because amidst all this intense discussion of wealthy donors, hidden HR budgets, digital data systems, and blame culture, we have to pause and ask, where is the patient in all of this?
The most important person.
How much of a voice does the actual person standing in the mud in the refugee camp have in how their healthcare is delivered?
That brings us to our final segment, the domain of beneficiary engagement. And to truly understand how frustrating and systemic this failure is, we have to link it all the way back to our first source.
The 2003 Good Donorship Agreement in Sweden.
Yes. Principle 7 of that historic diplomatic document explicitly mandated that humanitarian organizations must ensure the adequate involvement of beneficiaries in the design, implementation, monitoring, and evaluation of humanitarian response.
So 20 years ago, the global community made a solemn promise that the people receiving the aid would not just be passive victims. They would have a seat at the table in deciding how that aid is delivered to their own communities.
That was the noble ideal.
So what is the 2021 reality according to the survey of the top NGOs?
It is incredibly bleak. Only 13.3% of the respondents said that all of their projects actively incorporate beneficiary feedback.
13%.
Yeah. 37.5% admitted they never even designate a specific staff member to handle feedback from the community.
When they do bother to collect feedback, how do they do it?
The modalities are deeply passive and almost insulting. Almost 94% rely on suggestion boxes.
Suggestion boxes? Are you serious?
I am. Now, consider the context. In a crisis zone, where populations are deeply traumatized, where literacy rates might be incredibly low, where there are massive language barriers, and where refugees are often terrified of angering the authority figures who control their food and medicine, a wooden suggestion box, nailed to a tent pole, is hardly a robust mechanism for medical accountability.
It is entirely performative. It honestly reminds me of when you open a giant corporate app on your phone, like a major airline or a mega bank, and a little pop-up appears asking you to rate your experience from 1 to 5 stars?
Oh, yeah.
You click the 3-star button, but you know deep down in your bones there is literally no customer service team hired to read those reviews. And they are certainly not going to change the underlying code of the app based on your rating.
Yeah.
It is just a psychological trick to make you feel like you were listened to. That is exactly what these suggestion boxes feel like, but with human lives and public health at stake.
Your analogy is entirely validated by the quotes from the study itself. Participant 8 stated quite bluntly, and I quote, "Although we have always gathered some feedback as a matter of course, the universality of this is, in the most part, due to fairly recent donor requirements. I'm not sure everyone is really using the feedback we now receive effectively to improve quality."
Listen to that. Again, they only do it because the donor requires a box to be checked on the grant application. Did you ask the locals what they think? Yes, we put up a suggestion box. Check. Funding secured.
But the most chilling quote on this topic, the one that really exposes the void, comes from participant 13.
What did they say?
They noted that the only feedback the organization actively institutionally cares about is regarding sexual assault and severe financial fraud.
Oh.
Otherwise, quote, "there is no accountability mechanism in place."
So unless a staff member is actively embezzling thousands of dollars or committing a heinous criminal assault, the organization fundamentally does not care if the medical care they are providing is actually working for the community. The feedback goes straight into a void.
When you pull back and synthesize all three of our sources, the entire deep dive paints a very clear, if deeply troubling, picture of modern aid.
It really does.
The humanitarian system is heavily populated by deeply committed, brave, exhausted individuals who genuinely want to save lives. And they are relying on amazing, mathematically proven logistical frameworks like the brilliant 1982 drug models, Simmons and Walker, built to get physical supplies to the most dangerous edges of the world.
The people on the ground are good, the 1982 math is good, the logistics are a miracle.
But the modern institutional structure built around them is fundamentally skewed. The power dynamic flows entirely upward.
Upward to the donors.
The NGOs look upward to the donors to secure their financial survival. So their data systems, their reporting, their internal culture, and their behavior are all meticulously tailored to please the donor.
Right.
The power does not flow downward to the patients, because the patients, the beneficiaries, have absolutely no economic power and no political power over the NGO.
And no leverage.
Exactly. The system lacks any natural, market-driven, or democratic mechanism to enforce quality control.
Think about it this way. If I go to a bad local restaurant and get food poisoning, I don't go back.
Yeah.
I tell my friends, the restaurant loses money, and eventually it goes out of business. The market enforces quality.
Yes.
If a refugee goes to a bad NGO medical tent and suffers from public health malpractice, they cannot take their business elsewhere. They are trapped.
Entirely trapped.
And because they have zero leverage and because there is no international medical board hovering over the NGO to revoke their license, the entire system relies entirely on the internal moral compass of the NGO itself.
Right.
And as we've seen, that moral compass is easily compromised by blame culture, nepotism, and the desperate bureaucracy of grant funding.
It is a massive global system built entirely on voluntary accountability in an environment where the stakes could not possibly be higher.
Okay, let's recap this incredible, complex journey for everyone listening.
It's been a lot of ground to cover.
We started in 2003 with the noble diplomatic ideals of the Good Humanitarian Donorship Agreement in Sweden. The vital balancing act promises of humanity, impartiality, neutrality, and independence.
The foundation.
We explored how brilliant, painstaking mathematical frameworks from 1982 allowed us to predict disease and pack exactly the right medicines to save lives in the immediate chaos of a sudden crisis, proving that credible medical care is the foundation of all trust.
Which is still true today.
But then, through the sobering lens of a 2021 survey, we uncovered the dark reality that without real, independent regulatory oversight, even the most well-intentioned multi-million-dollar NGOs can fall victim to internal nepotism, a culture of hiding fatal mistakes, and a rigid bureaucracy that prioritizes pleasing wealthy donors over listening to the traumatized patients they are supposed to be saving.
Which leaves us with a final, profound, and somewhat urgent question to consider.
What's that?
The 2021 study noted that 168 million people were in need of humanitarian aid in 2019. But look at the current trajectory of the world.
Yeah.
With rising global instability, the proliferation of prolonged, intractable conflicts, and a rapidly accelerating catastrophic impacts of climate change, experts project that the number of displaced people could push toward 500 million in the coming decades.
500 million people completely relying on this unmonitored system for their survival.
Exactly. Can a system that is fundamentally built on honor systems, jurisdictional loopholes, hidden HR budgets, and voluntary accountability survive that kind of exponential scale?
It's a terrifying thought.
Or will the international community eventually be forced to create something unprecedented? Will we need a truly independent international regulatory body?
Like a global FDA or medical board for NGOs.
An entity with the actual legal power to issue an international medical license to these giant NGOs, and more importantly, the power to investigate, revoke that license, and penalize organizations that commit systemic public health malpractice.
It's a massive, necessary thought to mull over. We started this deep dive today talking about the comfort of an X-ray, the clean, highly visible line of a broken bone.
Right.
But as we've seen, diagnosing the systemic failures of the global humanitarian system is incredibly murky. The cracks aren't in the bones. They are hidden in the boardrooms, they are buried in the data software coded for donors, and they are lost inside the unread suggestion boxes. Thank you for joining us on this complex, incredibly vital deep dive. Remember, true learning means looking past the heroic, easy images of cargo planes landing on the evening news and demanding to understand the invisible, often flawed systems that are actually running the world. Goodbye until next time.